Ladies and gentlemen, thank you for being patient with us. My name is Eric. I am part of the Humanitarian Global Team. And I'd like to thank you for joining us this morning for our maternal infant young child webinar. And allow me to share my screen just to give you a small introduction as to who we are and what we do here at Humanitarian Global. So Humanitarian Global is an organization. We've been at the forefront of offering excellent training and to humanitarian professionals and development workers. And we have been there since 2015, and we have steadily been growing. We started as a CBO, and now we are a full institute. And we are here to offer, like I said, training to humanitarian and development workers. And some of the things we do, as you can see on my screen, of course, training being one of them, where we have bespoke courses that we offer to many of our participants and many of people like you who would want to upskill. And so far, we have trained over 1,500 professionals over the last 5 years, and the number keeps on growing. We are going to interact more about it. The second thing that we do is advocacy and consultancy. And in this part, we have a pool of experts who we work with, and through them, we are able to offer consultancy services and also advocacy services to people who are interested. Another thing that we normally do is community development, where we part of our projects in our community today that are important for the community growth. And also another thing that we do is promoting humanitarian and development work. And by this, we are able to partner with organizations that work with humanitarians and development workers to push the humanitarian agenda and to continue to try and achieve SDGs, the 17 of them. And that's a part of what we do. And of course, our training courses are online, and I will be sharing that as we continue. And because of time, I would want to welcome our key speaker for the day. Maregi, are you there with us? Irene?
Yes, I'm here with you. I hope you can all hear me clearly.
Yes, we can hear you. Maybe you can start by giving us an introduction about yourself, then you can start off the session. But before you do that, just to tell our participants that in case of any question, kindly use the chat option, the Q&A, sorry. In case of any question, use the Q&A to post your questions. And for those of you who are asking for the slides, we are going to send them, so there is no need of posting your email. We already have your email when you registered. So over to you, Irene, and thank you.
Thank you so much, Eric. Good morning, everyone. My name is Irene Maregi. I am a nutritionist by profession, and I have a key interest in areas of malnutrition, especially in prenatal, during the natal period, or during pregnancy and postnatal. That is the first 6 months after birth, and also a key interest in children under 5 years. I also am an expert here and a trainer with Humanitarian Global. So I am also one of the trainers where I facilitate learning sessions, and I invite you all to join me as we focus today our attention on malnutrition in infants less than 6 months old, which is a very critical area, because the first 6 months of a child's life really set the pace for the rest of their lives. So we are going to get into it. I invite you to join me throughout the session, and I thank you for joining me. And feel free to interact, ask your questions in the Q&A, and at the end of it, we shall get into those questions and really have a discussion. So our agenda for today, we are going to look at what nutrition is. So what do we mean when we say a child is malnourished? Symptoms of this malnutrition in infants that are less than 6 months old, classification of this malnutrition, and management of the same. So we start with the introduction. So infancy is a period of rapid growth, second only to the fetal period, with a pressing need to optimize nutrition to ensure adequate growth and organ development, with much emphasis placed on the developmental origins of health and disease, pioneered by the Barker hypothesis. Maintaining optimal nutrition is one of the vital aspects of infancy. Undernutrition during the fetal period due to placental, maternal, or fetal conditions can lead into intrauterine growth retardation with impaired organogenesis and decreased birth weight. And while fetal nutrition is not usually compromised, an extreme degree of maternal malnutrition occurs. Postnatal growth restriction in neonatal and postneonatal period is predominantly an acquired condition due to inadequate nutrient intake. Continued undernutrition during infancy is hence prone to growth failure or failure to thrive and metabolic disturbances that can persist into adult life. So for this part of introduction, we're saying that growth really of a human being in the life cycle starts during pregnancy or when the child is in utero or in the uterus. And during that time, malnutrition can also occur, or what we call intrauterine growth retardation. That means the baby, while still in the uterus, is not growing and developing like this. But that only occurs in cases of extreme maternal nutrition, that is in cases where the mother is extremely malnourished, then that is where we find that. But even with that being said, that it is really not something that happens very often, you still find that some children are born underweight, some children are born at a low birth weight. And if this undernutrition continues from birth now into the first 6 months of life or into infancy, we are saying that it will lead to growth failure, or the child will not thrive, which means, for example, the child will not achieve their milestones on time. The child will have a bit of mental retardation. They may not be able to communicate when they should. They may have delay, may delay while walking. And some of these undernutrition and the effects of this malnutrition can then be transferred into adult life. Low birth weight and rapid compensatory weight gain are independently linked to multiple morbidities in addition to altered growth, including increased risk of childhood and adult obesity, insulin resistance, increased leptin levels, and thus type 2 diabetes mellitus, as well as higher mortality in the future. The clinical impact of nutrition during infancy is best understood by measuring growth accurately. An in-depth understanding of the nuances of breastfeeding, formula supplementation, use of specialized formulas are key to ensuring adequate growth in infancy. So if a child was born with a low birth weight, and then interventions are done in such a way that this child gains weight rapidly in a compensatory manner, such that the child even surpasses their age mates, it means that when you do that, you risk this child getting childhood obesity, something that has recently been of concern to people in the health industry, because we are seeing a lot of cases of childhood obesity. So as much as we are talking about malnutrition and concentrating on the underweight aspect of it, or the lack of good weight per se, but there also is another side of it where if it is not controlled, there can occur overnutrition in children, and those children will risk having childhood obesity. And with childhood obesity, then comes in things like insulin resistance, which now brings in things like diabetes and other chronic diseases. In infancy, the best way of measuring growth or malnutrition is by measuring the weight and the height. And the more, okay, children under 6 months do not get a measured mark, but the weight and the height, and comparing that with the weight for age Z-scores. And for us to really understand malnutrition in context of children under the age of 6 months, we need to look into breastfeeding because, as we all know, children under 6 months of age, their main form of getting nutrients is through breast milk or breastfeeding. So we need to understand breastfeeding. We need to keep in mind challenges that come with breastfeeding. We need to keep in mind formula supplementation or the use of formula in case breast milk is not sufficient, and how some formulas, which we call specialized formulas, that we can use maybe if the child was born preterm or if the child was born with very low birth weight, how we can use some specialized formulas excuse me, to ensure that the child still grows well. Growth can often be interrupted by certain pathological conditions like gastroesophageal reflux, constipation, milk protein intolerance or allergy, and lactose intolerance, which often require dietary modifications. So even in children, in infants who are less than 6 months old, sometimes some conditions can interfere with the feeding and the growth of these children. For example, a child has GI reflux where they have too much acidity, and now that causes a challenge because they keep throwing up, then that will affect their breastfeeding. If a child suffers constipation, maybe as a result of the modified milk or the formula that they're taking, then of course that will interrupt growth. There are also children who have milk protein or lactose intolerance and allergies, and that also is not something we can ignore. So even in children under the age of 6 months, there can be instances where we need to modify their diet, or we need to modify their feeding if we need to work around issues like at the acid reflux or the constipation. So what is malnutrition? So malnutrition is a state in which the physical function of an individual is impaired to the point where he or she can no longer maintain adequate bodily performance processes like growth, pregnancy, lactation, physical work, resting, recovering from disease. So when we talk about malnutrition in children under the age of 6 months, we're basically saying that these children have impaired physical function and can no longer maintain growth or any kind of physical activity. And physical activity in children, I don't mean that they can walk or run or speak, but that they are lethargic. They do not have energy. They don't play. They are irritable. They really cry all the time. That's what I mean. But malnutrition in that context just means that they are not getting enough nutrients for them to sustain growth. And we cannot, of course, talk about malnutrition without looking at components of nutrition. So we have macronutrients, and macronutrients are the nutrients that we require in large quantities on a daily basis. That's why they are called macro. And these are carbohydrates, proteins, and fats. So unfortunately, in most populations where their economy is not well developed, our diets tend to be mainly carbohydrates as the source of energy. And then we have fats that also give energy, Then we have proteins that we use to build new tissues and we get from animal products like meat and eggs. We also get proteins from cereal. But in order for us to get a good balance of all these foods, we need to eat a variety of food. So we need to eat good sources of carbohydrates, we need to eat good sources of fats, we need to eat proteins from various sources, both animal protein and plant protein, so that when it's combined and it's a meal, it is balanced and we get the most out of it. The other component of nutrition is micronutrients. So these are divided into two, and micronutrients, when you hear of them, what comes to mind is mainly the vitamins and the minerals. But here in micronutrients, we've divided them into two. So the type 1 micronutrients are iodine, iron, vitamins A and C. Deficiencies in these micronutrients do not affect growth. So the individual can have with appropriate weight and still be deficient in these micronutrients. So the deficiency of type 1 micronutrients is not determined by anthropometric measurements. That is, you cannot determine if someone has low iron or low iodine by taking their weight or their height. But if they have deficiencies or they're not eating enough of these micronutrients, then they will get anemia or scurvy or impaired immunity. So they still affect the individual's health, but they do not necessarily affect their weight gain. And then we have type 2 micronutrients, and these are magnesium, sulfur, nitrogen, essential amino acids, phosphorus, zinc, potassium, sodium, and chloride. So these ones are essential for growth and tissue repair, and they are needed in small quantities, but the correct balance for good health. A deficiency will lead to growth failure measured by stunting and wasting. So unlike the type 1 micronutrients that cause deficiency diseases, the type 2 micronutrients are used by the body during growth to maintain growth. So if they are not provided for, then they will contribute to malnutrition in terms of loss of weight and stunting. There are also different categories of malnutrition. So we have acute malnutrition, which is categorized into moderate acute malnutrition and severe acute malnutrition. And these are determined by the patient's degree of wasting. And then we have a note here where we are saying that all cases of bilateral edema are categorized as severe acute malnutrition. And then we have chronic malnutrition, and it is determined by a patient's degree of stunting when a child has not reached the expected height for a given age. To treat a patient with chronic malnutrition requires a long-term focus that considers household food insecurity, feeding and hygiene practices, and public health issues. And children can have a combination of both acute and chronic malnutrition. So acute malnutrition is basically malnutrition that happens as a result of lack of enough nutrients over a relatively short amount of time. Chronic malnutrition, on the other hand, happens over a longer period of time, happens over sometimes even years. So that's the main difference. But a child can have both chronic malnutrition where they've not had enough nutrients over the years, and they're also not getting nutrients in the short term. So they have both stunting and severe acute malnutrition, moderate acute malnutrition. Now, severe acute malnutrition, or SAM, is further classified into kwashiorkor and marasmus. Some patients may have a combination of both, which is we call marasmic kwashiorkor, and patients with kwashiorkor are extremely malnourished and at a great risk of death. So there are many reasons why malnutrition happens, and there are also different consequences of malnutrition. So we look at the causes of malnutrition as explained by the WHO in terms of the immediate causes the basic causes and the underlying causes. So the underlying causes are, the immediate causes are inadequate dietary intake and disease. So if a child does not get enough food, or the child gets sick, then they are likely to end up malnourished. And then we have the underlying causes. Now these are at the household level. So this is as a result of household food insecurity, inadequate care, and unhealthy household environments, and lack of health services. So if you look at the diagram that we are seeing, or the illustration, you will see that the underlying causes directly lead to the immediate causes. So household food insecurity results into inadequate dietary intake. Inadequate care also leads to inadequate dietary intake, and an unhealthy environment leads to disease. So the underlying causes bring about the immediate causes, and then the basic causes bring about the underlying causes. So the basic causes of malnutrition in general are socioeconomic and political contexts, lack of capital, financial, human, social, and natural. So the basic causes are what cause the underlying causes. So if, for example, there is political instability, and that causes household food insecurity, then it's the political instability is the basic cause. If there is an economic crisis and that causes food insecurity, then that is a basic cause. So lack of food intake and disease are immediate causes of malnutrition. They create what we call a vicious cycle, where one makes the other worse, or they exacerbate each other. So malnutrition increases the risk and worsens the cause of infectious disease, and infection leads to malnutrition. This cycle is known as the malnutrition infection complex, and therefore inadequate food intake and disease must both be addressed to support recovery from malnutrition. Very important. And as you will see, when we get to the management of the steps in the management of malnutrition, there is a triage section, or an area where the child should be assessed for disease, because both lack of nutrients and disease, they both cause malnutrition, and we cannot deal with one and ignore the other. So we need to keep that in mind every time we deal with malnutrition, that we have to address both the disease state of the person, if the person is sick or if they have any infection, and also we deal with giving them enough nutrients. In addition, HIV, which frequently overlaps with environmental enteropathy, may contribute to immune activation and modulate HIV disease progression. So here there is a group of people who are HIV positive, and especially in children who are HIV positive, then the HIV virus really affects their immune system. And the immune system is also affected by malnutrition. So it becomes very critical to ensure that the immunity of these people is taken care of, because if the immunity is compromised due to malnutrition or due to infectious diseases, then you really end up in a cycle of malnutrition and then disease, and then that will accelerate the progression of HIV to AIDS. The interacting effects of infection and enteropathy drive a vicious cycle that can propagate severe malnutrition, which underlies almost half of under 5-year-old deaths. So this disease and malnutrition cycle, really severe acute malnutrition, difficult to deal with and difficult to really eliminate, especially in the developing nations. And unfortunately, as a result, over half or almost half of deaths of 5-year-old children and under, which is a vulnerable group, can be linked to either malnutrition or disease or severe acute malnutrition. So the underlying causes of malnutrition are food, health, and care, as we said. So inadequate household food security means the children are not getting enough food. Health, if there is limited access to health services or inadequate environmental health conditions, then it means that these people are exposed to a lot of diseases and are likely to get infections. And then there is care. So inadequate social and care household and the local community also affects how children are fed, disease disease development, and also health-seeking behavior if they seek help in time. And then we have basic causes of malnutrition. As we said, they originate at the regional and national levels, which affects the allocation of resources, and that influences what happens at the community level. So if we have things like geographical isolation, where some communities are kind of cut off from the market circulation of food or the economy, or if they do not have good infrastructure, then that will ultimately affect the nutrition status of the people in that community. So when you're assessing the causes of malnutrition in a community, if you realize that there is a big malnutrition community, you should look at the causes of malnutrition on all these levels, because as we said, basic causes cause the underlying causes, and the underlying causes cause the basic causes. So if you really, at the end of the day, want to get rid of malnutrition, we have to address the issues at the basic level. So now we are going to narrow it down and look at now malnutrition in 6 months in children less than 6 months old. So how do we assess for acute malnutrition in this group? So infancy is a period of rapid growth. So when a child is born, they start gaining weight very rapidly. In the first year, you will see that that child has gained weight, made many milestones. So during this infancy, then it means the child needs a lot of energy and a lot of good nutrition. So weight, length, weight for height, and head circumference are the primarily used markers for measuring growth rates in infants and children. Trends in growth patterns over time provide more valuable information than a single measurement. An infant within the normal percentile ranges, e.g. 10 to 90 percentiles for weight, may be failing to thrive if the growth rate stalls over a while. This might be missed by taking a one-time measurement that falls within the acceptable range. The growth rate is the fastest in the first 3 months after birth, reaching about 30 grams per day. The growth rate subsequently slows down to about 15 grams per day by 3 to 6 months, and about 10 grams per day from 6 to 12 months. So while we are assessing malnutrition in infants, it is key to remember that what we mainly use to assess growth is a trend. So we need more than one measurement over a sustained period of time. And this is why it's important for mothers to be encouraged to attend postnatal clinics or the mother and child health clinics. And when they come in, it is important that the child doesn't just get attended by the nurse and given immunization and sent home, but we need to take the weight measurements, the length measurements, calculate the weight for height over a period of time, so that we can tell if the trend is going up or the trend is going down. Because measuring the weight or the height of a child only at random times, or without really a reference point of knowing whether it's going up or it's going down, might really get us to a point where we are not able to tell if the child is developing normally or growing as they should or not. The length and head circumference also increase rapidly in the first year of life, increasing by about 25 centimeters and 12 centimeters respectively. This period of rapid growth is best captured using the appropriate growth charts from the World Health Organization. The World Health Organization growth charts are the primarily used charts for infants and children 0 to 24 months. Furthermore, the WHO growth charts were devised based on a diverse international population and are more applicable to infants that are breastfed and set higher standards for weight gain, making growth appear to fall short of the standards. So we generally use the WHO charts that are, you can find that resource in their website. But when these growth charts were being developed, where you can see the percentiles and the z-scores, these growth charts were developed using a diverse population. So I've had people ask me, well, there are children who because of the genetics seem smaller or have a leaner body. There are children who, because of genetics, might seem like they're shorter than their age mates. But all of that is considered, and that's why we look at percentiles. We do not, it's not a fixed number that a child should be a fixed weight by a certain age. So the reason why we use those charts is because they develop them after doing research using a big number of children and making observations, and all things are considered. So even if the child might be leaner than others because of genetics, or might be shorter than others because of genetics and things like those, they will still fall under the normal percentiles as long as they are not malnourished. So how do we triage and diagnose acute malnutrition? So the first step is the initial screening and referral. Successful management of EMAM requires that an efficient active case finding and referral system is established to ensure that individuals receive appropriate care in a timely manner. In some areas, community units have been established, and if a community unit exists, then screening should take place within this unit. Where a community unit does not yet exist, a comprehensive community screening and referral process should be established and linked with the closest health facility. Where most of the cases of malnutrition you find might be referred to the hospital from the community setup, especially where the role of the community health workers and the community health volunteers has really been given a good place in society. So if the community unit has been established, that means that we have community health volunteers, we have community health extension workers, we have community health workers, then they can do the initial screening and refer for further screening or further management. If there isn't an established community screening and referral system for children with malnutrition, then the local or the closest health facility should take a task and come up with a way of educating the community and finding a way of getting to those children that are malnourished in the community. So the screening and referral process can include any of the following. One, community health workers trained and supervised by community health extension workers ensure that they measure the mark of a child who is 6 to 59 months and check for edema. So children, if they find children with a mark of less than 11.5 and bilateral pitting edema, then they refer them for assessment at the health facility. If they also find children with a mark of between 11.5 and 12.4, they also refer them. If they get an individual with a mark of between 12.5 and 13.4, then who are at risk, they also refer them. So basically, these community health extension workers and the community health workers to be able to use some measurements or look out for some signs of malnutrition and refer those cases to hospital, even if the mothers are not aware that their child might be having malnutrition. In some instances, other persons in the community can be trained to screen and refer. So for example, we find that there are mother-to-mother support groups. There are other groups within the community, like the women groups, the roundtable banking groups. We can train these people to be able to screen for malnutrition early, because if we can catch malnutrition in the early stages, then we are really able to reverse it. Then screened and referred from any other point of contact with health support programs or initiatives. So a child can also be referred through other community organizations or NGOs or other health workers. Maybe the mother had come to the clinic for immunization, but the nurse realizes that this child needs further nutrition assessment. They can also refer them. Maybe the child was sick and the doctor realizes that this case needs a nutritionist, then they can also refer them. There's also a ripple effect of caregiver to caregiver referral from the community to the health facility, and there is also self-referral. So the mother can bring in the child herself, or even there can be a ripple effect where if some mothers are aware of what malnutrition is, how it looks like, the symptoms, then they can talk to others, and then that creates a ripple effect where if a mother identifies that my child might have a problem, then they bring in the child. And then step 2 after referral is when you get this child, you conduct a medical assessment so that you can see if the child has emergency signs and immediately transfer them to a qualified health worker for treatment, while quickly assessing for some using MUAC and/or present bilateral pitting edema. So when a child comes in with suspected malnutrition, you need to conduct a medical assessment and quickly also assess for malnutrition. But there are things that we call emergency signs. So malnourished children sometimes are at a very great risk of death. So when you get these children, you should always look for emergency signs. Is this child breathing well? So we look at if the child has severe respiratory distress. We look at central cyanosis. How is the heartbeat? We look at signs of shock. Is the child in shock? Is the child unconscious or in a coma? Is the child convulsing? Does the child also have severe dehydration? So if a child has these emergency signs, then we take up that case as an emergency, and our priority shifts really from treating the malnutrition to saving the life of this child. So because most times malnutrition and disease happen concurrently in these children, these emergency signs really can't save the life of these children. So a quick assessment of nutritional status is also important at this point. So treatment of protocols of children with SAM differs from standard protocols, and appropriately trained health facility workers involved. So if a child has been diagnosed with SAM or severe acute malnutrition, then their treatment should be taken up ideally by a qualified and trained health worker who understands the process of treating malnutrition, because it is a process, and also understands the different formulations of things like F75, F100, the correction fluids to balance the electrolytes, and one who will also work within a team, because if the child is sick, then the one taking care of the nutrition of the child also needs to work together with the other healthcare workers. Step 3, if no emergency signs are found, then conduct an medical assessment to determine if the child has any priority signs. So we have emergency signs and we have priority signs. So the emergency signs is literally an emergency where that child can really die if we are not careful. So we need to act quickly. But if you do not find any emergency signs, then you look for the priority signs. So the priority signs is tiny baby who is a sick infant less than 2 months of age. If they have a fever, very high temperature, if there is major trauma, if the child is in severe pain, if the mother reports poisoning, if the child is severely pallor or pale, if the child is restless, irritable, or floppy, you're holding the child, but the child doesn't seem as if they can hold themselves up. If the child is also in respiratory distress, if they have an urgent referral letter, if the child is severely visibly wasted, if the child has edema or swelling in both feet, and if the child has severe burns. So these priority signs, they need prompt assessment and should be moved to the front of the queue. So if you work within an NGO or even a health center, and people have queued, but you notice in the queue that there is a child who has this priority signs. They seem not to be breathing very well. They seem lethargic. They seem pale. They have things like severe burns. These are not children that should really be kept waiting for long. They are given priority over the other patients. So how do we classify malnutrition? So that was looking at the triage, and the triage is really looking at how you deal with the patients when they come in. And so we've seen that you look for the emergency signs and then you look for the priority signs. But if you call that, then how are you going to look at this infant and say that this is malnutrition, or you classify that this is malnutrition and the infant is less than 6 months old? So determining acute malnutrition for infants less than 6 months, that is some is identified by the presence of bilateral pitting edema, weight for length, Z-score, that is -3 Z-scores, too weak to suckle or feed effectively, and mom is identified if weight is static or the infant is losing weight at home. So for us to say that this child less than 6 months old has severe acute malnutrition, we have to take the weight and we have to take the length. And if the child has bilateral pitting edema and their Z-score, their weight for length Z-score is -3 or below, and this child is too weak to suckle, that even if the mother tries feeding them, does not have even energy to suckle, then that is a severe acute malnutrition case. For moderate acute malnutrition is when the weight is static. Static means that the weight is not increasing. So maybe the child has been assessed for weight, and you can see in their graph, as I said, we look at the trend. So the trend is showing you that this child has not gained weight in the last 3 or 4 months, and the child now has begun losing weight when they're at home. Then that is a moderate acute malnutrition case. In addition, the infant identified with SAM or MAM, as well as the infant at high risk of wasting, will receive community-based care to support mother, infant, and young child feeding practices to address possible related inadequate feeding or care practices. So when we diagnose SAM or MAM in children, we should also that help beyond just treating this SAM or MAM in the hospital, but ensure that the mother also gets community-based support back at home, because this mother needs support, whether it is due to lack of education, they need to be educated. If they need care in terms of being shown how to breastfeed or being helped with food, then we need to extend that help back at the community level. So this is a table that is showing in summary what we have said. If the infant is less than 6 months old, the weight for length Z-score is -3 and below, edema is present, the child is too weak to suckle or feed effectively, And there are the danger signs that we have talked about, that is the emergency and the priority signs. There's recent weight loss or failure to gain weight, then that child has severe acute malnutrition. So now we have triaged the child, we have diagnosed the child with severe acute malnutrition. So what next? So next is the management of this severe acute malnutrition. Now, because of the evidence that we have that breastfeeding is the best way to provide nutrients to children less than 6 months of age, even when a child is diagnosed with severe acute malnutrition, our ultimate objective is to ensure that they return to full exclusive breastfeeding. So we want that at the end of our treatment, that the child has gained enough energy to be able to suckle, that if the challenge was things like latching and the mother had challenges breastfeeding, that we have taught the mother and supported the mother to be able to latch the baby well and to be able to successfully breastfeed, so that when the mother goes home after the child is discharged, then the child can be able to gain weight and grow and thrive on breastfeeding alone. So children younger than 6 months who are diagnosed with SAM are treated in inpatient therapeutic care. So all the SAM cases of children under 6 months, we treat them in the health facility. They are not outpatients. They should not be admitted and treated with the ready-to-use therapeutic food in an outpatient therapeutic program, because it is not suitable for infants less than 6 months old. So we cannot use the option of the RUTF, which is available for children 6 months and above. Infants who are malnourished are weak and often do not suckle strongly enough to stimulate an inadequate production of breast milk. The mother often thinks that she herself has insufficient breast milk and is apprehensive about her ability to adequately feed her child. The low output of milk is due to inadequate stimulation by the feeble infant and can be exacerbated by self-doubt from the mother. Breast milk supply is demand-driven. That is, the more the baby feeds, the more breast milk the mother will produce. So here we have a situation where an infant is malnourished, not even have enough energy to suckle. And because they are not suckling enough, then the milk production is compromised. When the milk production is compromised, then you find that the mother now starts struggling and starts blaming herself and thinking that it's because she's not able to get enough breast milk. So if the child is not strong enough to breastfeed or to suckle, then the milk production is affected, and then the confidence of the mother is affected, and then that even worsens the breast milk supply. So remember, breast milk production is demand driven. That is, the more the baby suckles, the more the breast is stimulated to get to produce more milk. So if the infant has not been breastfeeding well, then it means that the stimulation has gone down, and therefore you can also expect that the mother will not have enough breast milk. Infants should be breastfed and treated in a separate space from the older malnourished children. This can be in a breastfeeding corner, as the aims are to increase breast milk and for the mothers learn, and because the mothers learn from each other, and because treatment is different from older children, the infant should be together in a specific room that can be monitored and kept quiet. It is important that these infants are not put at risk of cross-infection from older children. So when we are admitting these children, ideally, they should be in a separate space from the other older malnourished children, because these children under 6 months of age are more vulnerable at getting diseases. And as we know, cross-infection happens in hospital setups. So because we will also want these mothers to feel comfortable, to feel supported, it is better if we set apart a room for them, a space that is quiet, that is conducive for them. An infant presents with bilateral pitting edema. If an infant presents with bilateral pitting edema, wait to calculate the weight for length z-score until the edema has resolved. This infant is admitted for the treatment of some based on bilateral pitting edema only. Now, the reason we are saying that if bilateral pitting edema at this point, and it is plus, then we should wait until the edema has resolved, because it will affect the weight reading and the weight will not be accurate. So these are the steps to manage malnutrition in these infants. So we have the initial screening that we talked about, but now we refer we have the screening we talked about, but now we look at the breastfeeding and care practices, because we said our objective is to return this child to full breastfeeding. Growth faltering and illness in infants and young children should be recognized early and be addressed or be referred for specialized care. Health services should identify infants at risk routinely and refer for support and all treatment, or refer to sites with skilled health workers and appropriate equipment. So infant weighing scales should have 10 to 20 gram precision, because standard spring scales are not accurate for this age group. So also the weighing scales that we use should be as precise and accurate as possible. And then number 2, we conduct a medical assessment for the emergency signs. If we do not find any emergency signs or priority signs, then nutrition screening occurs. So we look at, when you're doing nutritional screening, we look at bilateral pitting edema, we look at the weight, we look at the length, we look at visible severe wasting. Also, we conduct a thorough medical assessment, which also includes a physical examination and a medical history. And then step 6 for these infants, we assess breastfeeding practices. So these breastfeeding practices means that you look at the frequency and you ask the caregiver or the mother how often the child breastfeeds, the technique that is being used, that is positioning and attachment, and duration on each breast. The reason we are assessing breastfeeding is because this child relies on breastfeeding for their nutrients. So if the issue is that there is poor technique, for example, the positioning and attachment, then we need to assess for that and address it. If the mother is not letting the child breastfeed for a long enough time on one breast before changing to the other breast, and the child is not getting the hind milk, then we also need to assess for that. Or maybe even the mother is not frequently enough. Maybe her baby sleeps a lot and she lets the child go even for 6 or 8 hours without breastfeeding, both day and night. So the breastfeeding assessment is really important, because it will let us know really how has the feeding been and the challenges that the mother might be having with breastfeeding. So we also look at how many times the baby is passing urine, because this tells us if the child is getting enough milk. If the child is passing urine less than 6 times in a day, then it shows that the child is not feeding adequately and they are at risk of getting acute kidney injury. And then we also have mode of feeding. We also assess if the child is breastfeeding, if the mother is using a cup and spoon, or a bottle, because all these affect intake. The feeding, is the child responsive and eager to feed? Are they active, or has the child been too weak that they have to be forced to eat? Also, we look at hygiene while preparing to breastfeed. So especially in cases where the mother expresses milk, or we use milk formula or alternatives, then hygiene is really important, because now we are looking at the hygiene of washing these cups and spoons, hand hygiene, if the water is safe and treated, all of that. And then we look at also the psychosocial factors contributing to inadequacy of intake, such as social isolation, depression, and stigma. So you also have to assess the psychosocial factors of the mother. Maybe the mother herself is malnourished. She does not have enough food. Has she been isolated back at home? Maybe this is a teenage mother or mother, and she has been isolated, and she's depressed, or she's being stigmatized, and therefore she's not in a good state of mind to be able even to maintain breastfeeding. And then we have use of vitamin and mineral supplements and alternative practices. So has this mother been giving this child any other thing? Are they giving them supplements? Do they have alternative practices where they are giving other things that are not breast milk that might be affecting the health of the child? So nutrition supports diet, frequency, and suckling technique feeding approaches of infants less than 6 months of age with severe acute malnutrition should prioritize establishing or re-establishing effective exclusive breastfeeding by the mother or the other carer. If an infant is not breastfed, support should be given to the mother or female caregiver. So sometimes you find that by the time you're coming into contact with this child, the mother has already given up on breastfeeding. So we can reestablish, or one of our goals is to reestablish or ensure that the mother can be able to relactate. That is, we can get the mother back and the child to a place where they reestablish breastfeeding. During the period where exclusive breastfeeding does not provide enough breast milk for the infant to gain weight appropriately, according to the growth curve or the 2011 WHO growth velocity standards, relactation should be supported and stimulated by supplemental suckling with a milk supplement. So in cases where you have admitted the child and the breast milk is not sufficient, then we can stimulate breast milk production using what we call the supplemental suckling technique. Infants with some without edema should be supplemented with expressed milk, a generic infant formula, or F100 diluted. Young infants with edema should be supplemented with expressed milk for F75 until the edema has resolved. And diluted F100 should never be given, undiluted, should never be given to infants less than 6 months old with some because of the high renal solute load and risk of hypernatremic dehydration. So where the breast milk is not enough, we either use expressed breast milk, we use infant formula, or we use dilute F100. We do not use F100 undiluted. So breastfeeding on demand should be done, or offer breastfeeding every 3 hours for at least 20 minutes or more if the infant cries or demands for more. The infant should be breastfed as frequently as possible. So we should really encourage, and if you can see, I keep repeating it, but it's because that is the key goal of managing malnutrition in infants less than 6 months old. We really want to encourage and stimulate production of enough breast milk that the child can continue on and thrive on breast milk alone. So between half hour and an hour after a normal breastfeeding session, Give maintenance amounts of milk supplements at 130 ml per kg per day, distributed across 8 feeds per day using the supplemental suckling technique. Give F75 for infants under 6 months with bilateral pitting edema until the edema is resolved. The quantity of milk supplement is not the infant starts to gain weight. So even if we are going to, or if there is need to supplement the breast milk, then the supplement milk, whether it is expressed breast milk or infant formula or dilute F100, it is given after the child has breastfed. So we always encourage the mother to breastfeed the child first, and then after half an hour or an hour after the breastfeeding session, then we supplement, because priority is given to breast milk. So how to make the milk supplements? So when the ready made up formulas are available, that is dilute F100, which is in packets into 675 ml of water instead of 500 ml to make dilute F100. If F100 diluted is not readily available, the infant can be fed with the same quantities of commercial infant formula diluted according to instructions on the tin. So if you do not have access to F100 so that you can dilute it, you can also just use infant formula, the commercial infant formula. But infant formula is really not our best option because it's not formulated to promote rapid weight gain. But if that is the option that is available, then that is the option that you should use. The progress of the infant is monitored by the daily weight and weight growth velocity. If the infant loses weight or has a static weight over 3 consecutive days, but continues to be hungry and is taking all the milk, progressively add 5 ml extra to each feed. The infant should be weighed daily with a scale graduated to within 10 to 20 grams. In general, supplementation is not increased during the stay in the health facility. If the infant starts gaining weight, gradually decrease the milk supplement by 1/3 of the maintenance intake so that the infant is stimulated to take more breast milk. If the weight gain is sufficient and maintained for 2 to 3 days, after gradual decrease of the milk supplement, stop the milk supplement, because then that means that the child has started gaining weight on breast milk alone. If the weight gain is not maintained, re-increase the amount of milk supplement to 75% of the maintenance amount for 2 to 3 days, then gradually decrease the amount again if the infant starts gaining weight. So if the infant has a static weight or starts losing weight, even you're managing them, but continues to be hungry, then increase the supplemental milk that you're giving with 5 ml to each feed. And remember, because the infants rapidly start gaining weight, we weigh them on a daily basis, ideally at the same time. So if you've been taking their weight in the morning, then we really want to maintain weighing them at the same time every day if possible. And then if the infant starts gaining weight, then you gradually start reducing the milk supplement because you want them to continue gaining weight on breast milk. So if the child sufficiently maintains the weight gain for 2 to 3 days, even after you have decreased the supplement, then you stop the milk supplement. If the weight gain is not maintained, then you re-increase the amount of milk supplement for 2 to 3 days, then you decrease. So basically what we are trying to do is we want to encourage the child to breastfeed and stimulate the mother that they get enough breast milk to satisfy them and to restart the growth process and to start gaining weight. So when you take the weight measurements and over 2, 3, 4 days, the child has started gaining weight, then we start decreasing the milk supplement, the one that we are giving after breastfeeding, so that the child is encouraged to breastfeed more and continue the weight gain just using the mother's milk. So when we talk about the supplementary suckling technique, that this is a technique where the child still gets the supplementary milk, but they get it while still stimulating the breast milk to produce milk. And we use an NG tube or nasogastric tube most of the time, which is a very thin tube. And then we cut the tip of that NG tube, and then we put that one end of that NG tube in a cup of expressed breast milk, and then the end of that one tube is put in the cup. The tip of the other tip of the tube is put on the breast, and then the child is given the breast, is offered the breast to breastfeed in the normal way. So the child is suckling on the nipple. If the mother is not producing milk or enough milk at that point, the child is still getting the supplemental milk from the cup. And this is what we mean if you can look at this image. So the child is still at the breast and is suckling. So they are still stimulating the breast of the mother to get milk. But we have a cup here that has supplemental milk. So even if the breast is currently not having any milk, the child is stimulating because they are suckling, but they are getting milk from the cup. And now how this works is that the suckling really stimulates the breasts to start producing enough milk. So at first, the cup should be placed 5 to 10 centimeters below the level of the nipple so that the milk does not flow too fast and distress the infant. And so the weak infant does not have to suckle excessively to take the milk. As the infant becomes stronger, the cup should be lowered progressively to about 30 centimeters below the breast. And you should never place that cup when you're doing the supplementary suckling technique. It should never be above the level of the nipple because it will flow too quickly into the baby's mouth, and that causes a risk of either inhalation or the baby can choke. So the mother holds the tube at the breast with one hand and uses the other to hold the cup. So because we still have a bit of a way to go, we are going to look at some of the questions as we take a bit of a break, a bit of a water break before we can resume. So I'm going to go through some of these questions in the Q&A before we continue. So Jacob asks, what is the approximated age that a baby should start walking? And can we say that delayed in walking or crawling of an infant is contributed by malnutrition? And how do we correct such conditions? So there are what we call milestones, and some of the milestones in a child's first year is the starting to crawl and starting to walk of a child. And the approximate age is from around 9 months to 18 months. The baby can start crawling, walking while holding themselves up on things like tables and furniture, or if you hold their hand, they can take a few steps. So from around 9 months to 18 months, and it's a range because children develop at different paces. And delay in milestones, yes, is also can also be attributed to malnutrition, because it's one of the indicators of lack of growth. Because when a child grows, then they should have achieved the milestone in time. How we can correct such conditions is we can look at the root cause of the delay in the milestone, because malnutrition is not the only thing that can cause a delay in milestone, but it's one of the causes. So we can look at the nutrition status of the child, and the child can also be assessed to see if it's an issue that needs physiotherapy or occupational therapy. So yes, such conditions can be corrected, and children also sometimes may have delayed milestones, but catch up later. Then what is the normal, Mitsuk asks, what is the normal range of head circumference at birth? It's around 35 centimeters, approximately. And then Anonymous asks, well, I have always realized there is release for mothers who undergo cesarean sections and you find babies starve, yet we talk about exclusive breastfeeding for 6 months. In such a circumstance, what should we do to resuscitate the baby? So in the first day of life, the child only needs at least let's say 5 to 10 ml of milk every feed. So even the small drops that mothers say, my milk has not come in, it's very little, is actually sufficient. But where we find that there was a delay in milk letdown due to cesarean and due to delayed latching and pain and things like those, then what we can do is to reinstate or to re-lactate. That is, even if the mother is not currently exclusive, we can reintroduce breastfeeding, because as long as the mother has the willingness and the support to be able to breastfeed the child, then we can reattach the baby. We can help the mother by stimulating this breastfeeding. So in such circumstances, to resuscitate the baby, I think you mean to reintroduce breastfeeding, because we do not let the baby starve until the mother is, it should not happen that a baby starves because their mother does not have milk. We look for options as healthcare workers. It's not appropriate that we let a baby starve because the mother has undergone cesarean section and is not able to find breast milk. Even if there is delayed milk, we can relactate, we can reestablish breastfeeding. But in the meantime, we should look for alternative feeds. That mother, that baby should not be let to suffer or to really get dehydrated because the mother does not have enough breast milk. One last question before we go on break, kindly. So Akinyemi, you're asking, kindly explain the type 1 and type 2 micronutrient again with examples. So the micronutrients I said are divided into two. So micronutrients in general, we are talking about proteins, sorry, not proteins, the vitamins and the minerals. They are further divided into two classes. So we have type 1, and this includes iodine, iron, vitamins A and C. And deficiency in these type 1 micronutrients do not affect growth in terms of weight gain, but they lead to micronutrient deficiency diseases. So the micronutrients that we are saying is for example, iron or iodine. For example, insufficient quantities of iron, insufficient intake of iron will not directly affect weight gain, but it will cause anemia. So these type 1 micronutrients will lead to micronutrient diseases. Now, type 2 are micronutrients that are involved in the growth and the day-to-day growth and repair of the body. So lack of these type 2 micronutrients of things like magnesium, sulfur, nitrogen, potassium, sodium, all of these, if they are not eaten in sufficient quantities, will lead to growth failure. That is, they have a direct impact on things like gaining weight and stunting. So I hope I have answered you sufficiently, because this is just in general. All of these micronutrients have their own role in the body, but this is just in general. So I request Eric to take over for me for a few minutes before we continue with management of malnutrition, because we still have a few slides to go. Just a short water break, and then I'll be right back with you.
Maternal, infant and young child nutrition program focuses on addressing the challenges experienced in feeding infants and young children, as well as meeting the nutritional and biological needs of lactating mothers. Undertaking a certificate course prepared by Humanitarian Global ensures you get in-depth knowledge and understanding in nutrition in pregnancy and childhood. You get to learn more about nutrition in pregnancy, breastfeeding, pediatric nutrition assessment and complementary feeding. Also, you get an understanding of malnutrition and its management. You will gain knowledge on malnutrition and its management in infants. Get to also learn about inpatient and outpatient management of severe acute malnutrition. Thirdly, you will understand community nutrition response. This unit will cover management of moderate acute malnutrition, community mobilization, emergency nutrition response and nutrition information, education and communication. Apply for this course today by visiting our website www.humanitarianglobal.com for more details.
86% of organizations value professionals that upskill to advance their careers. It's never too late. Enroll for a self-paced online course to begin upskilling in monitoring, evaluation, accountability and learning, water, sanitation and hygiene, disaster risk reduction and management, food security and nutrition in emergencies, procurement and supply chain management, human nutrition and dietetics, maternal and infant young child nutrition. Apply today to enjoy a 10% discount.
Irene, thank you for guiding us through the first session and also answering some of the questions. I think at this point, I'd just want to show our participants some of the courses that we do or that we have for them that they can join. So you'll allow me to kindly share my screen again. Ladies and gentlemen, some of the courses that we have, as you can see on my screen. Irene, I hope you can see my screen. Ian, kindly confirm if you can see my screen.
Yes, Eric, we can see your screen.
Thank you for that. So some of the courses that we offer are under procurement and management. That's one of a good course for the procurement professionals. We also have an analysis for the SPSS. We have, of course, disaster risk management. That is a certificate level. For the procurement, we have it in 3 levels. We have the postgraduate, the diploma and the certificate, as you can see. And then for the nutrition, we do have the PGD nutrition. That is our expert level. We have the diploma, the intermediary, and then we have the beginner level, which is a certificate. And we also have a few courses for food security. As you can see, we have the diploma level and the certificate level. And of course, for our session today, which is a maternal, infant, and young child. We do have a certificate level course available for you to join. And we also have under the meal course, that is a monitoring, evaluation, accountability, and learning. We do have the certificate, the diploma, and the PGD. And also we do have a WASH, that is water, sanitation, and hygiene. Under the same levels, we do have the certificate, diploma, and of course the postgraduate levels. And we are also planning to add on a few more courses with us. So we are going to be launching that soon. However, if you need any other training, we do offer trainings. They can be either physical or online trainings. You can reach out to the chat section. One of our staff, Ian, who is here with me, will be getting back to you, and we can have a conversation on how to arrange for a training session with you and your organization or your friends, those who require any training. And also for the fees, I think Ian has been sharing the different fee structures for the certificate levels. That is a beginner. It takes about 3 months, and we charge $500 for it. For the diploma level, which is our intermediary level, we charge $1,000 for it. It is 6 months long. And for this level, you also get to have a journal paper or to write a journal paper. And then for the PGD, that is a postgraduate level, which is our advanced level. It takes around 12 months to complete. And we charge 1,500 USD. And of course, for the PGD, apart from the the courses that you take, you also get to undertake a project that is going to assist you just to implement some of the things that you have been learning. And for this month of September, we are offering a 10% discount for anybody who is going to register for any of the 3 levels. That is the certificate, the diploma, and the PGD. So if you want to join or any other questions, you can reach out to us. You can use the chat section just to ask for more information. You can leave your contacts there also. And we are going to get back to you concerning the courses that we have. That is all from me. Irene, I don't know if you're there.
Hello.
Yes, Irene?
Yes, I am back.
I think we can continue with the second session due to time.
Yes, I think I'll answer a few more questions before we go on, because time is not on our side, and we might not be able to cover all that I had prepared for today. So I think I'll answer 2 or 3 more questions, so that when we get back to it and we get to a conclusion, at least I will have addressed a few more concerns. And then for those questions that we might not be able to answer, I will get in touch with you, and we can continue the discussion even after our Zoom session has ended. So Kiemi says, please, I heard much earlier that MWAC cannot be used to assess a child under 6 months of age. Did I hear this well? Yes. This is contrary. Why is MWAC not used? So MWAC is not recommended for as an assessment tool in children under the age of 6 months. It is used for children above 6 months of age, and this is because there's no evidence that it is a reliable measurement at this age. Because remember, MWAC, which is the mid upper arm circumference, measures really, or is an indicator of muscle wastage. So at that age of children, of infants who are less than 6 months old, is really not, there's no data to indicate that it's a reliable measurements. We majorly just rely on weight for length Z-scores at that age, and then we assess for the danger signs, and then we look for the bilateral pitting edema. We look for, we do breastfeeding assessment for infants less than 6 months, but infants 6 months and above, MWAC is definitely one of the tools that are used. So yes, you had that right, and that is the reason. So Ivan asks, could you please throw more light on the weight for length Z-score? I have not understood how it works. So the weight for length Z-scores are just a way for us to assess the growth of the child, where we measure the weight of the child, and then we measure the length of the child, and then we have WHO weight for length charts, and we compare the length of the child versus the weight of the child, and there are different charts for boys and for girls. So we look at their length versus their weight for children who are less than 6 months old. So we do that, and then there are Z-scores. So the weight for length is classified where there is -3 SD, which means they are severely malnourished. And then we have -2 SD, which means they are moderately malnourished. And then we have -1 SD, which means they are at high risk. So that is how it's classified, but we use the WHO weight for length charts, and we read the Z-scores. So it's just a tabulation where you check the length of the child against their weight. And then can a reading of 12.6 to 13.5 be declared mom-free? That is normal, but at risk. When we are making a diagnosis of malnutrition, we do not rely on only one indicator. And that is why we are saying we do a nutrition assessment. So if you find that a child has a MWAC, I assume the 12.6 to 13.5 centimeters, I'm going to assume it's centimeters, and it's the MWAC of a child. If the child is at risk, then it has to be because there are other indicators that tell you that this child is at risk. So that means that even if the MWAC is okay, you're classifying this child at risk, maybe because they have been losing weight, or maybe because they are not feeding, or maybe because they have other signs of malnutrition. So unless we have more evidence that indicates that this child is at risk, maybe they have been losing weight, they are very sick, or something like that, then you know that that MWAC is for a healthy child, for an at-risk child. So what side effects that Rutuf can give to the infants that make it not suitable for them? So I addressed this, and I said that it's because of the development, and the excretory system of the infant at 6 months old is not able to efficiently and appropriately digest and excrete RUTF, because you see, first of all, it's a solid food, and at 6 months, below 6 months, the child is not supposed to be fed on solid foods. Two, because it is a therapeutic food, the concentration of those nutrients might cause some sort of dehydration to the child, or might be too much for their digestive system. So we do not use Rutuf because the child has not developed enough to be able to handle it. So I think I am going to reach there for now. and continue a bit so that we can at least cover the last of management of malnutrition in children who have prospects of being breastfed. So I'm going to get back into it, and then if we still have enough time, then I'm going to head on to the next part of our presentation. So let me share my screen, just a minute. So here we are. So we have talked about the supplementary suckling technique, and we have seen that we can use that to stimulate production of breast milk, especially where you find mothers who have really low quantities of breast milk, but they really want to breastfeeding. Then that is one of the really effective ways to ensure that we can reinitiate breastfeeding. And then the other key important part is surveillance. So there are some very critical things that we should keep an eye on when we are managing the nutrition of these children. So you should take body temperature twice a day or 4 times a day for hypothermic or febrile children. That means that we should keep an eye on the temperature of these children, because you remember high temperatures or fever is a priority sign. So we should check their temperature twice a day or 4 times a day if the child has had fevers. And then weigh the child at fixed times every day. Assess and record the degree of edema, that is from 0 to plus daily. Record the patient feed intake and source, that is, did the child feed using oral NG tube? Are they on any IV fluids if they're sick? Record if they were absent at mealtime or have refused to eat or have vomited. Assess the standard clinical signs daily, that is, how many stools has the child passed? Have they vomited? Do they have signs of dehydration? Are they coughing? What is their respiration? You assess their eyes, their ears, skin condition. Do they have any new wounds? And then there should be a full medical examination daily. These the clinical signs and the medical examination is mainly tasked towards the clinical team. And then you should measure the height or length for children less than 87 centimeters every 21 days. So every 3 weeks, if the child clinic and they have not had their length taken, then every 3 weeks they should have their length taken. But in our scenario, because we are dealing with malnutrition and they're inpatient, you need to assess the weight of the child daily. You need to assess their edema daily. You need to assess their food and fluid, their fluid intake. Sorry, there's no food intake, it's fluid intake. And their clinical signs and body temperatures, they need to be assessed every single day. Now, this is because one, children are vulnerable and their diseased condition can deteriorate very fast. On the other hand, they also recover pretty quickly. So if you do not take the weights daily, for example, you will not catch or capture any slight weight, and you will not then be able to assess if your breastfeeding attempts, if they are being successful or not. If you do not assess for things like how many times the baby has passed stool or how many times the baby has vomited or has had an episode of diarrhea, then you will not be able to tell if the child is getting enough breast milk or if the child is able to tolerate or finish the amount of supplemental milk that you're giving. So some of this surveillance is critical in the management of malnutrition in these children. So what is the discharge criteria, or at what point do we say that the child can go home? So in infants less than 6 months, you discharge when it is clear that they are gaining weight at 5 grams per day for at least 3 consecutive days on breast milk alone after the supplementary suckling technique has been stopped. And infant is clinically well and alert, and infant has no medical problem and edema is resolved completely. So we discharge the child when our objective of reestablishing breastfeeding to a point where the child is growing and gaining weight on breast milk alone. When we reach that point, then we can discharge the child. Also, the child should be clinically well and alert. So even if the child has started gaining weight, but they are still on treatment for other clinical diseases, then we cannot discharge them. If the infant still has a medical problem that has not resolved, or if the edema has not yet resolved, then we cannot discharge them. So for infants less than 6 months, you have to ensure that they are medically well, they do not have any disease or infection, there is no edema at all, and they have been able to maintain weight gain for 3 and more days only on breast milk. And then there is follow-up. So after discharge, we do not just let the cases go. We need to ensure follow-up because sometimes children relapse back into malnutrition. So the follow-up for these infants is very important. The mother should be linked to the supplementary feeding program or other community-based support systems if they exist. It's important for the mother to receive high-quality food to improve the and quality of breast milk. It's also important to monitor the infant's progress, support exclusive breastfeeding, and inform the mother on when to introduce appropriate complementary food at the age of 6 months. Each infant should also be checked for immunizations. So upon discharge, the work does not just stop there. So we need to support this mother to ensure that they successfully exclusively breastfeed until the child reaches 6 months of age. And then we support the mother with education and with other support programs. If the mother is food insecure, then we link her to organizations or other community support programs that will ensure that this mother gets enough food to be able to continue breastfeeding. Also, you should monitor the progress of this child. You can do it every 2 weeks after discharge, that the child comes in for assessment. And if you have community health extension workers or community health workers, they are also key to ensuring that even when the mother goes home upon discharge, that they have support. Also educate the mother on appropriate complementary feeding practices when the child reaches 6 months of age, that she is well equipped and knows how to introduce these foods at the right time and in the right way to prevent the child from getting malnourished again. The mother should also be encouraged to follow through with the immunization schedule for the child, and the infant should also be checked for immunizations, because as we know, immunizations are important to help prevent the of disease. So these immunizations are also one of the things that we need to follow up on. And so then we get into management of malnutrition in infants less than 6 months old with no prospect of being breastfed. So in some instances, it is not possible to encourage breastfeeding or to reestablish breastfeeding or for the child to even be breastfed at all. So you can find an infant less than 6 months old who is malnourished and is not on breast milk. So there are special circumstances when a child less than 6 months cannot be exclusively breastfed, e.g. abandonment, a child being orphaned, medical conditions, or when a child is living with HIV, when a mother, who is living with HIV meets the criteria for exclusive replacement feeding, with the aim of treatment of infants under 6 months, with some with a caregiver with a potential of breastfeeding, is to decrease milk supplements gradually until they are gaining sufficient weight on breast milk alone. The aim of the treatment of infants under 6 months with some without the prospect of being breastfed is to receive milk supplements until they are old enough to take semi-solid or complementary food. So our objective changes if the child has no prospect of being breastfed. So then our objective becomes that we treat the severe acute malnutrition of these children and ensure that they receive adequate quantities of breast milk substitutes, whether that be formula or any other kind of milk, until they are old enough to be able to take semi-solid. They are old enough for complementary feeding. So when there is no prospect of being given breast milk, infants less than 6 months old with severe acute malnutrition are treated according to the standard protocol of severe acute malnutrition in stabilization, transition, and rehabilitation phase. However, the following dietary modifications must be applied, and although the admission criteria is the same as other malnourished infants, the discharge criteria is different, because this time we are not discharging them on gaining weight on breast milk, but we are discharging them on other criteria that shows that the severe acute malnutrition has been resolved. So the feeding in stabilization phase, here we give formula milk or F100 diluted or F75 in case of edema at 130 ml per kg per day across 8 feeds per day. So the amount of milk we calculate using that formula 130 ml per kg per day. So the amount of milk the child receives is dependent on their weight at admission. And then we feed by cup and saucer or by NG tube if the child is not able to take sufficient milk by mouth, or if they are too weak, but we do not use bottles. We do not use the feeding bottles. We use cup and saucer or cup and spoon if the child is able to feed, or if the child is not able to take sufficient quantities, we use an NG feeding tube, but the NG should not be in place for more than 3 days and is only used in the stabilization phase. So we want to discourage the use of NG tubes in the feeding of 6 months, because it exposes the child to a lot of things. The child is irritated. It can also cause some infection because of it's a foreign body it's a foreign thing in the body. So the use of NG tube is only used in very severe cases, and we advocate that it's not used for more than 3 days. As soon as the child is able to feed orally, then we switch to the cup and spoon. So the criteria to progress from the stabilization phase to the transition phase are both a return of appetite, the child has appetite, and edema starts resolving. That is, if they had edema of 3++, then it goes to plus. Then we move now to phase. So feeding in transition phase, you give formula milk or F100 diluted, provided at 150 to 170 ml per kg per day, or increased by 1/3 of what was given in the stabilization phase. So if you can, if you're keen, you can see that at this transition phase, we have increased the quantity of milk that we are giving. So in stabilization phase, we are giving 130 ml per kg per day. In transition phase, we are giving 150 to 170 ml per kg per day. or you increase, if the child is not able to finish the quantity after you've calculated with 150 or 170 ml, then you increase the quantity you are giving at stabilization phase with a third until the child is able to sufficiently finish the milk. So the criteria to progress from the phase to the rehabilitation phase are a good appetite, that is, they are taking at least 90% of the formula milk or F100 diluted prescribed for them in that transition phase, and complete loss of bilateral pitting edema or minimum stay of 2 days in the transition phase, and no other medical problem. So if the appetite has returned and they are able to finish at least 90% of the milk, there is no edema and there is no medical problem, then we move to the rehabilitation phase. So in the rehabilitation phase, now we also increase the milk or the F100 diluted to 200 ml per kg per day, or twice the volume in the stabilization phase. So as you can see here, in infants who are not receiving any breast milk, then we are significantly increasing the milk as their appetite improves and as they are able to finish the feeds. So mothers or carers should receive relevant support to enable safe preparation and use, including at home when discharged. So if the mother is going home or the caregiver is going home and the infant is not, the option of breastfeeding is not available, so we need to teach these mothers how to safely prepare the milk formulas, or if it's an milk or another milk alternative, then we should also ensure that before discharge that these mothers are taught, or these carers are taught, how to prepare sufficient quantities and do it in a safe way. So criteria for discharge: infants less than 6 months who are admitted to inpatient care can be transferred to outpatient maternal, infants and young children nutrition support when all clinical complications, including edema, are resolved, and infants have good appetite, are clinically well and alert, and weight gain on either replacement feeding is satisfactory. So if the child has started gaining weight after or during the stabilization phase, the child has gained sufficient weight at more than 5 grams per kg per day for at least 3 exclusive successive full days, and then the infant has been checked for immunizations and other routine interventions, the mother or carers have been linked with community-based follow-up and support, then is discharged. So the child should have reached a Z-score of -2 Z-score and gaining weight at 20 grams per day. There is no bilateral pitting edema, and the child is clinically well and alert. So if you look at these discharge criteria in comparison to the discharge criteria for the infants being breastfed, you will see that it is different, because for the infants being breastfed, we did not include the Z-score. We just said that the child should have started gaining weight and maintained the weight gain over 3 or more consecutive days. But if the child has no prospect of being breastfed, then we include the weight for length Z-scores and also the weight gain as part of the discharge criteria. But in both cases, whether the child is being breastfed or not, we discharge children when they are medically healthy, they do not have any disease conditions, when they are clinically well and alert, when all the edema has resolved, and when the child has been gaining weight. So that is when we discharge them. So other considerations for these children. So at discharge, the infant can be switched to infant formula. The carer should have been adequately counseled before discharge, as we said, because they need to prepare adequate quantities of the formula or the replacement feed. And then the caregiver must have knowledge and facilities to prepare this formula milk safely. So you also have to carry out an assessment of whether the mother has access to safe drinking water, whether they have the support that they need to ensure that they can be able to prepare this milk in a safe way. And then whenever formula milk is provided as parts of management of severe acute malnutrition in infants, it should not confuse or compromise the wider public health message concerning exclusive breastfeeding for infants less than 6 months. So you might be wondering why I am mentioning infant formula, and we have a strong public health message that we advocate for exclusive breastfeeding for 6 months. Well, the infant formula is being mentioned because at the community level, in the day-to-day living, you will find situations where milk is entirely out of the picture. It's not an option at all. So when we do not have an option of breast milk, and this child has to be fed, and this child needs an alternative which is healthy, which is safe, and which will provide them with the most nutrients that we can, even if breast milk is not available. That is why the infant formula milk is being mentioned. So that option that we are mentioning does not mean that we do not advocate for exclusive breastfeeding. Exclusive breastfeeding still remains the best option for feeding infants and feeding children. And it is only infant is only an option where breast milk is not available or cannot be sustained, because the child still has to be fed. So that brings me to the end of my presentation for today. After discharge, we still have the same considerations of follow-up for the child, even if they are not being breastfed. So we still do the same follow-up. We still do the same daily measurements for children, even if they're not being breastfed. So those remain constant. The only difference is that in children who have no prospect of being breastfed, we have the stabilization phase, the transition phase, and then the what is the other phase, the rehabilitation phase. So that is the only difference. And the other difference is that because we do not have the option of breast milk, then we give F100 diluted or formula milk in place of breast milk, so that even children who do not have access to breast milk and have malnutrition, they can still be rehabilitated back to a good nutrition status. But even for these children, we are going to conduct appetite tests. We are going to look at how many times they pass stool, so that we can see if they are taking sufficient quantities of milk. We are going to take daily weight measurements. We are going to take length measurements after 3 weeks. We are going to follow up on their immunization. We are going to give the carers or the mothers support through community programs that provide support. We are going to involve the community health extension workers to ensure that this mother has support back home. So all of that is still going to be done. The only difference is how we manage it as as health workers in inpatient. So remember we said that all cases of severe acute malnutrition in children under 6 months are treated as inpatient. So we do not have cases of severe acutely malnourished children under 6 months who are outpatients. So that is also another critical thing to remember. So at this point, I think I'm going to tackle a few more questions before time gets away from us. So we have Martha Nzioka who asks, a 1 month HIV exposed child weight 1.8 kg whose mom not on heart can exclusively take breast milk, only 10 mLs, can't miss AFAS criteria, day 7 since admissions was on IV fluids, but EBM highest attained is 10. The birth weight was 2.6 kgs. Is it advisable to give the root F100 therapeutic formula? Giving therapeutic formula, is it mixed feeding or part of routine medication? So in this instance, as from my assessment, in this case where you have a HIV exposed child and the mother is not able to sustain or give enough breast milk even after expressing, child has lost a significant amount of weight, then yes, it is advisable to give dilute F100 therapeutic formula. In this case, because breast milk is not sustainable, so we have to intervene at this point, because this child we cannot let this child continue to deteriorate, but we have to address the severe acute malnutrition. So it is being given as part of routine medication in my assessment of that situation. So Akinyemi says the supplementary technique is interesting. I have never seen this. It is a technique that is used and has been used in my part of the country. So it was part of my training as a nutritionist, and I am glad I have shared it with you, because it's an effective way of stimulating breast milk production, especially where the mother has breast milk, but the quantity is not sufficient. So I am glad that you have learned something new. James asks, which one is better for some infants? For some, infant formula and dilute F100. F100 dilute is the better option, especially if the child still has prospects of being breastfed. Then F100 dilute is our number one option. So Lura Emmanuel asks, what is the normal weight or height range of an infant or child less than 6 months? So at birth, we know the normal weight range for a child is 2.5 to 3.5 kilograms. And then the normal length is from 45 centimeters. Okay, but then the normal weight range now from there is that a child should progressively gain between 300 to 500 grams up to a kg of weight every 4 weeks. So from there, it's progressive. But at birth, the normal weight range is 2.5 to 3.5 kgs. Height ranges from 45 centimeters. Then how can we identify a child having both acute and chronic malnutrition? So chronic malnutrition, the key indicator is mainly stunting, where the child has a shorter height for their age. Acute malnutrition is assessed using the weight for height z-scores or weight for length z-scores. If the child is above 6 months, we also use MWAC. We also use the clinical signs, where we look at things like the bilateral pitting edema. We look at paleness. We look at the child is irritable and all that. And then full meaning of SAM and MAM. SAM means severe acute malnutrition. MAM means moderate malnutrition. Then James asks, in some instances, I have seen caretakers being advised to give goat milk for children under 6 months when the parents are not able to breastfeed adequately, especially in twins or triplets, or when the mother dies and no other options. Is it a good practice? Well, in life, we have the ideal, and then we have situations where we have to work with what we have. So the ideal in any instance, the ideal feed for children in any instance is breast milk. Now, in absence of breast milk, we have to find an option that is adequate and safe and sustainable. So the next best alternative is infant formula. If infant formula is not available, then yes, goat milk or animal milk that is modified is used as an option. It is not the ideal, or it is not what we advocate for, but if the circumstances are such that this child needs nutrition in some form, and breast milk is not available, infant formula is not available, then modifying animal milk then becomes our sustainable option. Then we have, is the protocol used for managing malnutrition in infants under 6 months different from children 0 to 24 months? I think you mean children 6 to 24 months. And yes, the protocol is different, because in infants less than 6 months, we have different objectives. The objective for children under 6 months, our main objective is to reestablish growth using breastfeeding alone, or to reestablish growth if the child is not being breastfed, using milk formula until the child can take semi-solid foods. In children above 6 months, then we have different protocols, because these children are not relying on breast milk alone. These children have already started complementary feeding. These children can be treated using RUTF. So the protocols are different. Then Jacob says, sorry for asking too many questions. No, I don't think there's such thing as too many questions in class. Which deficiency does a child have if he or she always picks up things like soils and stones and anything that to them? This question, I'm going to say that sometimes it can be an indication of deficiency in calcium or something such micronutrients, especially calcium and iron. But in some instances, it's a stage where children are, because I don't know the age of the child, there is a stage where children tend to pick things and put in their mouth, and it has nothing to do with malnutrition. It's more of a developmental stage. But if it's not about a developmental stage, and it's something that has happened and they are just really drawn to certain things like soil, then you might want to look into calcium and iron deficiency. And then Simon asks, how do you manage an infant under 6 months who is malnourished and the mother has difficulty in breastfeeding? So that is where we talked about the supplementary suckling technique, where if the mother has difficulty breastfeeding and the issue is stimulation, then we can use the supplementary suckling technique to encourage the baby to suckle, and that suckling is what really stimulates the production of breast milk. If there is any other issue with breastfeeding, then we can address the issue. If the issue is attachment and latching and positioning of the baby, then we can teach the mother how to properly latch and attach the baby. If the issue is things like sore nipples or cracked nipples, then solutions for to heal the nipples and then reestablish breastfeeding. If we have other challenges like inverted nipples, then all of those we can address. So it depends on what the root cause of the challenge is. So if the challenge is something that has to do with technique, we can teach them. If it's challenges to do with things like positioning, then we can teach them. If the mother feels they do not produce enough milk, then the solution is to stimulate breast milk production by encouraging suckling. Then how can how can we manage malnutrition in rural areas where health facilities is not stabilized? Like in South Sudan, a risk of reaching out to those living in the rural areas is difficult. So these are is that the humanitarian community tries to address. So in areas where you do not have health facilities, it's a real challenge, and I think it's an issue where we need to establish that infrastructure first, because as I said, we need to treat severe acute malnutrition. In some cases really need to be inpatient, so we need the infrastructure. So this is a challenge that should be taken up by the community, by the humanitarian community there, even involving other stakeholders like the government, because without these infrastructures, it is very challenging to address malnutrition. And then Bank Shalom asks, in a situation where a mother has not enough breast milk for her infant, while the child has no medical complication, what is way forward to do as a community health worker? So you need to take the mother in for a breastfeeding assessment so that the health worker can establish the reason why breastfeeding is not being successful. Because if the mother does not have enough breast milk, we need to establish why. If the issue is stimulation, if the issue is the mother does not have enough social support, if the mother needs more support in terms of getting healthy foods and getting healthy support system around her, so you should refer the mother to a health center for a breastfeeding assessment. Isaac asks, Simon, I answered this question. Why Rutuf is not recommended for managing malnutrition in infants under 6 months is because it can lead to complications like some type of dehydration. It's also not appropriate because the infant under 6 months digestive and excretory system is not developed enough to handle the RUTF. Isaac asks, sometimes the child under 6 months is not malnourished and the mother doesn't have breast milk, what can we give as the milk supplement? In this case, since if can increase the weight of such child. So if the child is not malnourished and the mother does not have breast milk, my question is, what has the child been feeding on? Because if the child is not malnourished and the mother does not have breast milk, then there is something they have been feeding the child. Otherwise, it wouldn't make sense. So if the mother has been giving infant formula, or if the mother has been modifying animal milk, then we need to establish what it is. But as long as the child is not malnourished, dilute F100 is not an option. So dilute F100 is a therapeutic milk that is only used if the child has severe acute malnutrition. So if the child does not have malnutrition, we encourage and support the mother to breastfeed until she has enough breast milk, or we establish if she has a way of giving and maintaining a different type of feed, like the infant formula. Then we have, okay, I think some of these questions are directed towards Eric.
Yes, Irene, I think I will look into the questions. I'll be answering some of them that are directed to us.
Yes, so these questions, let's see.
Maybe we can just skip them over. We'll just answer the ones that are relevant for the webinar. And my team and I can get back to the rest.
So how does malnutrition affect development? So malnutrition, Mohammed, affects negatively affects development. So it delays in development, it causes failure to thrive, it causes delay of milestones, it causes it compromises on the mental and physical development. How will you assess edema in children less than 6 months? What if no signs of SAM are present? So if there are no signs of SAM present, then the child is healthy, if I get your question. So if the child has a good weight for length Z-score and there are no signs of SAM, then that child is nutritionally healthy. To assess edema, you do a finger press test where you press your finger into a part of the foot of the child and press for about 5 seconds, and then you release your finger, and then you see how long it takes for the skin to rise back up. If it takes a long time for the skin to rise back up, for that then to be cleared, then the child has edema. Because a person without edema, if you press, even right now you can try, if you press into your hand and you do not have any edema and you release, then the skin goes back to normal. But if you have any swelling or edema, then that remains there for quite a few seconds. Thanks so much, Peter. I would like to know what we can do to mothers who have illnesses like mastitis. So illnesses like mastitis, where there has been an infection, then we have to treat the infection first and then reestablish breastfeeding. So if there is something like mastitis, or the mother has an infection in the breast, then that has to be treated before we can reestablish breastfeeding. So James asks, do we need to start with F100 diluted even if there is medical complications other than edema? So here is what I said, that we need to work as of a team. So when a child has medical complications, so the child has things like high fevers, the child is dehydrated, we have to resolve the medical complications that are high priority or emergencies before we can deal with the malnutrition. So, and that is why I talked about during triage, there are some signs, there are some emergency signs and priority signs that we look for, and then those are taken care of before we get into resolving their malnutrition. Then Simon asks, how do you manage the malnutrition of infants 6 months and above? So that is a whole entire subject, because when we are treating malnutrition in infants 6 months and above, it's a bit more complicated in terms of there are different procedures for different types of malnutrition and different scenarios. So I invite you to get in touch with us. We do cover that in our course for the maternal and infant young child nutrition certificate, where we will go through malnutrition in older children or infants above 6 months. So because of time and the limitations that I have right now, Simon, I'm sorry, I cannot get into that, but we will get in touch with you and see how we can resolve that for you. Solomon asks, for a child, no prospect of breastfeeding, can the option of wet nurse be explored before infant formula, since most of the as a point cannot have the resources to buy infant formula? Yes, the option of a wet nurse is a good option if it is available, because it is essentially breast milk. So that is an option. If there is a carer who can be a wet nurse, then that is definitely going to be given priority, and that is going to be our number one option. James asks, does maternal malnutrition affect the quality and quantity of breast milk? Yes, because there are some nutrients that change in the breast milk depending on the mother's intake. So the mother's quality of health affects the quantity and quality of her breast milk. And then Peter asks, I would like to know if expressed breastfeeding is encouraged and when is it needed? Expressed breast milk is also, so when we define breastfeeding, we do not just talk about the baby feeding from the breast only, but we talk about the child feeding on breast milk, whether that breast milk is gotten by direct suckling or by exclusive or by expressing the breast milk. So yes, it can be encouraged, especially in situations when the child is too weak to suckle and the mother has breast milk. Then we encourage the mother to express, and then we feed the child if the child is too weak to suckle, with a cup or a cup and spoon. Also, in some instances when the mother is from the child and the child needs to feed, the mother can express breast milk and store it well, so that the child still gets the nutrients in absence of the mother. So I think that's it for the questions in the Q&A. And Eric, I think you can moderate, and we can get into a few more questions in the live session before we conclude.
Yeah, I can do that, Irene. Thank you for guiding us through the second part. And now, ladies and gentlemen, you can come to the part where you can raise your hand, or you can speak. And to do that, you can raise your hand, and I will allow you to unmute your microphone and speak. And we are going to start with Solomon Obidigbo. I hope I got your name right, Solomon. Solomon, you may unmute your microphone. Solomon.
Hello.
Yes, morning. Yes, Solomon.
Hello, good morning. Yeah, yeah, can you all hear me?
Yes, I can hear you.
Okay, so thank you for the presentation. It was really quite detailing and quite informative. For me, I've actually asked the question I wanted to ask. I raised my hand before so that I can be able to ask a question concerning the a wet nurse, because when the presenter was talking about for children that has no prospect to breastfeed, you can place the child on infant formula. So for me, I was actually trying to find out if actually a wet nurse can also be sought for, because most especially in places where we implement this nutrition is actually in a remote setting, and most of them are peasant farmers and they cannot be able to afford to buy this infant formula because they are very expensive. So can we explore the option of a wet nurse before we start talking about infant formula? And if there are no wet nurse, and how do the question of the infant formula, is there any other thing that we can do further? Like in some localities, they try to use some of the recipes found around to be able to create something like F100 diluted. I don't know if that option also can be explored. Thank you.
Thank you for your question. I think I had answered it partly. And yes, our thoughts, and in case our witness is not found, and the people, because of the socioeconomic status, are not able to afford infant formula, then our next best option is modified animal milk. So if a wet nurse can be found, then because breast milk still remains the best option, then the wet nurse is a very best option. If that is not available and they're not able to sustain infant formula, then we look into modified animal milk. Hello.
Okay, thank you.
You're welcome.
Thank you for that, Solomon. I hope that is clear. Ismail Abubakar, are you there with us? Ismail Abubakar, you may unmute your microphone.
Hello.
Yes.
Good morning, everyone.
Good afternoon from this side.
How are you?
Yes, you may ask your question.
Okay, my question is that the cost piece is S500, so I need to know in Naira, right?
Yes, and
Nigerian Naira, huh?
sorry, Ismail.
Hello, can you hear me?
Yes, I can hear you now.
Okay, my question is that the cost piece is what I see in your screen, right?
Yes.
500, right? So I need to know how much is for Naira, for Nigerian Naira, but?
For the Naira, allow my team to get back to you for that.
Okay.
Yeah,
okay.
My team is going to get back to you in a minute.
Okay.
I don't know if you have any other question or comment.
Later on.
Okay, thank you so much. Thank you so much, Ismail. Misuk Ivan. Misuk Ivan.
Yes, I hope you're getting me.
Yes, I can hear you.
Yeah, I'm very appreciative for the lectures that have been provided today.
Yes.
Me as a person, I've just completed a bachelor's in midwifery.
Yes.
And actually, I'm yet to graduate. But I would like to inquire whether immediately after my graduation, I can be admitted for postgraduate diploma in what? In nutrition and dietetics. And then because I will have to go in for internship for 1 full year, so I don't know whether I can be admitted before I do my internship. Thank you.
Thank you, Ivan. Allow my team to get back to you in a minute, and they are going to discuss with you. concerning your question. Thank you, Ivan. Weye Drame, it's Wuye. I hope I got your name right. Wuye, you may unmute your microphone.
Yes, good morning.
Yeah, good afternoon from this side.
Okay, good afternoon from Kenya.
Yes.
Yeah, I have those few questions.
Yes.
Like in the Gambia, I'm from Gambia. In the Gambia here, we are encouraging mothers to do exclusive breastfeeding before complementary feeding. So in the event that the child has some complication, what type of feeding practice you can recommend to the child mother who is practicing exclusive breastfeeding? Can you hear me?
Yes, I can hear you.
What kind of complications? Complications that prevent breastfeeding?
If the child is seriously malnourished before 6 months.
Is malnourished.
Yeah.
If the child is malnourished before 6 months, then we need to treat them using procedures like we have discussed, where the child needs to be rehabilitated to get back to gaining weight healthily in a steady way. So that is a case where you need to refer the child to a health center for management. Yes, that is not something that the mother can sustainably do at home, because the child needs daily monitoring. The child needs assessment. We also need to assess if the breastfeeding is being done successfully and in the right way. So if the child is severely malnourished and they are under 6 months, then they should be referred to a health center for further management.
Okay, thank you.
You're welcome.
Thank you, Wuye, for that question. I can see another hand up. Leju Oliver. Leju, you may unmute your microphone and ask your question. Leju Oliver. Leju. Okay, as we wait for Leju, Ali Abdi Hassan, you may unmute your microphone.
Yes, are you getting me?
Yes, I can hear you.
Thank you very much for providing us this very important and meaningful training.
Yes.
I have a question, and my question is, when a child is at the risk, or when a child is very malnutrited, and we don't have or is not available the issue of mother breastfeeding of his mother and animal milk, what are the third option or the third thing that we can support him or survive him, the child?
So if the mother does not have milk and you do not have animal milk or infant formula, then wow, that becomes a very challenging situation. Let's say I search for more options, because those are the only options that are viable at that point, when we take into consideration the development stage of the child and their ability to digest and utilize food. So below the age of 6 months, milk is really our only options. Any other thing that we do when there is no milk is something that is not age appropriate for that child. So those are simply our best options: the mother's milk, infant formula, or modified animal milk. But now we start getting into discussions about giving food or porridge or things like those. And at that age, the child has not yet developed enough to be able to efficiently digest and benefit very much from those foods. So I am yet to know of any other options apart from milk for children under the age of 6 months.
Thank you very much. In addition to this, some mothers, they have the milk, but they produce a little much of milk. So to produce more milk, what are the best meal that we can provide them? Because nowadays, in mostly now I'm in the part of the Ethiopia, eastern part of Ethiopia, mostly the climate is very dry, and the food which has value, it comes very slow. And our females, they are dying. Our children, they are dying lack of shortage of milk for their mothers. So to be produced or to product more liters of milk to the mothers, what are the best foods that we can provide with our wives or our sisters?
Okay, to boost quantities and quality of milk produced for breastfeeding, the mother needs to be on a balanced diet. So that means that the mother needs all kinds of food. They need enough carbohydrates, enough proteins, enough fats. They need a variety of vegetables, variety of fruits. So it's not specifically one specific food, but the mother needs all the kinds of food that make up a balanced diet. The mother needs all of that. And then the mother also needs to take adequate amounts of fluids or liquids. So the mother should take enough water. The mother should take, if there is milk available, the mother should take even tea. So just a balanced diet with all the nutrients and also enough fluids should be sufficient to boost milk production.
Thanks. I get the point.
You're welcome.
Abdi, I hope that is clear, and thank you for asking the question. Jacob Garang, Jacob, you may mute your microphone.
Hello, good afternoon, Mr. Eric.
Good afternoon, Jacob.
And the presenter. Hope everyone is okay there.
Yes.
Yeah, my question is, first of all, let me congratulate or rather appreciate the presentation. Everything has been very clear, informative, and well presented. I would appreciate that. And my question is about a child who has lost appetite, child who is already above 6 and doesn't want to breastfeed anymore. Maybe the breastfeeding has reduced. Sometimes the supplements given is also not taken by the child. Child just seem to be, refusing things. So can we give maybe multivitamin or anything that can help maybe boost the appetite of this child? That is my question. Secondly, I would also like to say on, that is now to you as the admin, not on the presenter, that, the courses are really very informative. And I know through some of the people that we've been interacting earlier on, I will see a way of at least trying to connect them to you so that they can at least add something to whatever they already knew. Because people are outside there, but they are not having information about areas where they can, upskill or rather can add knowledge on whatever already they knew. So thank you for having given us the Humanitarian Global and the presenters who are also knowledgeable. Thank you.
Thank you for your appreciation and your comments. Your question is how we can boost the appetite of a child who is above 6 months of age. So an assessment needs to be done, and we need to look into how the child is being fed, because it might be just that the child is being fed in an aggressive manner or in a way that the child feels as if it's some sort of punishment. And children are also social people. So first of all, look at the feeding environment and try and make the feeding time a positive experience for that child as well. Number two, if the child does not have enough or adequate appetite, as you say, you can try and give the child a lot of fruits and a lot of vegetables to boost the appetite, and also give small frequent meals rather than forcing the child to finish a bowl of food in one go. Maybe you can one meal into 2 or 3 meals, where the child is fed every 2 or 2.5 hours, rather than having main very major meals that are 2 or 3 in a day. You can also try feeding small quantities spread out throughout the day instead. Also, ensure that the food is cooked in a way that is appealing to the child, because sometimes you find people prepare food for the child and the food is not appealing or tasty. So you find people are just serving the child boiled food or food that is mashed without any texture or any taste. So and also look at the food you're giving the child, and ensure that it is prepared in a way that it is appealing and also tasty to the child. So try and make the feeding experience be a good experience for the child. So look at it beyond the child is refusing to feed, but also think broadly in terms of what environment are we providing during feeding time? How are we feeding the child? Can we split these meals into smaller meals? Can we give food with a more colorful plate? Can the food be prepared in a way that it is tasty? Can we also include the child even in our own meal times, so that the child feels that they are part of the family and we feed together? So all of those are things you can try and look into that can help your child feed better.
Thank you so much. Thank you so much.
You're welcome.
Thank you, Jacob, for that question. And ladies and gentlemen, allow me to bring the session to an end because of time. However, you can allow me to share my screen, and I can show you to where to share the question in case we did not get to answer your questions. So once again, just give me a minute. Irene, can you let me know if you can see my screen?
Yes, I can see your screen.
Yeah, so if you go to our website, that is www.humanitarianglobal.com, we have the HG community, and this is our forum where we have different humanitarian and development workers, and this is a space for them to come and interact, to come and ask questions, to come and discuss on various things. And after you create, once you create an account, you'll be able to see such a page. And for this page, we have the different groups, if I may call them so. We have one for nutrition. We had one for breastfeeding that was created a while back. And we can come and continue the conversation about breastfeeding here. That is from a previous webinar that we had on 16th July. We also have different groups for the different training or different courses that we have. I think you can see a wash group, a meal group. And at the top, once you again go to the top, we have a page where you can see our incoming webinars, past webinars, and those that are coming ahead. For example, we had one for nutrition and dietetics where we looked at diet therapy. We did that a few days ago. We also had one on a meal. We've had one today on a maternal, and this coming Thursday again, we'll have one on food security, still led by the very able Irene Maregi. And so you can also look at the different logins that we have, or the different sessions that we are going to have. And finally, again, once you go, if you may allow me to go back, to our website. We have our different social media pages here at the top, and I'd like to direct you to YouTube. And we have our own YouTube page where we have the recordings of all our previous webinars. I'm waiting for it to load, should be in a minute, yes. So if you go to, again, YouTube, Humanitarian Global, again, you can get to see some of the different webinars that we've had. All the recordings are here, starting with the very last one that we had for meal, which is how to set up a complaint feeding mechanism. Again, the nutrition one is here, diet therapy, and the list goes on and on. Our last food security, again, is still there. We still had the role of breast milk. So those are the different videos that we have on our YouTube channel. And with that, ladies and gentlemen, allow us to come to the end of this session. We are grateful that you're able to join us today, and we are hopeful that we will see you during the next session that we are going to have, that is this coming Thursday, where we are going to be talking this time about food security. And we really hope that you're going to join us. So from everybody, from Humanitarian Global, my team and I, we wish you a good afternoon or a good morning, depending on where you are from or where you're listening to us from, and have a good day ahead.
86% of organizations value professionals that upskill to advance their careers. It's never too late. Enroll for a self-paced online course to begin upskilling in monitoring, evaluation, accountability and learning, water, sanitation and hygiene, disaster risk reduction and management, food security and nutrition in emergencies, procurement and supply chain management, human nutrition and dietetics, maternal and infant young child nutrition. Apply today to enjoy a 10% discount.